Thank you, Dr. Anthony. And these are purely my take-home messages. These are subject to change. So regarding the first trial, upfront cytoreductive nephrectomy. So whatever evidence we have is predominantly a retrospective study with regards to the era of immunotherapy and cytoreductive surgery. But the meta-analysis of all these retrospective studies provide additional support for that. Whether we would do upfront or delayed cytoreductive nephrectomy is not still clear. So probe 1 SWOG S1931 is an ongoing study which would actually address in the era of immunotherapy whether cytoreductive nephrectomy would help these patients. Till then, the cytoreductive nephrectomy should be considered on a case-to-case basis rather than a blanket therapy. Coming to the second trial, subcutaneous versus intravenous nivolumab. I think it's a no-brainer that if you have a subcutaneous nivolumab, you are going to use that. We have the PK data with Dr. Sleep as presented. They're shown to be equal. So we would probably follow subcutaneous nivolumab if it is available. And third, belzutifan and everolimus. Dr. Sleep had an extensive discussion. The quality of life, progression-free survival, and the overall survival is better with belzutifan compared to everolimus. But the OS data is not mature, but it's showing a very positive trend. So in advanced RCC, after 2 lines, after TKA and immunotherapy, probably we would consider belzutifan if it's available. We don't have it readily available as of now. And my own 2 abstract presentations. Again, there are no new information which we have gained, but favorable risk, probably at least in low burden cases, probably you can consider sunitinib or an equivalent TKI. They might actually be as good as, or even sometimes even better than an IO TKI combination. So that is one information which is reiterated in these 2 trials. And CBM 588 along with immuno or immuno TKI seems to be very interesting, but it's a very really small data, cannot be practice changing as of now. We'll have to wait for further data before we start practicing. And regarding cabozantinib versus sunitinib in non-clear cell RCC, again, non-clear cell RCC itself is a very broad classification. You have very many different types of that. So but with regards to the trial, as a blanket statement, cabozantinib is not superior to sunitinib, and both can be used probably interchangeably. Probably would stick with sunitinib. And we have had first-line lenvatinib pembrolizumab in non-clear cell RCC. It's already a standard of care. And the long-term update was presented, which shows that pembrolizumab has durable anti-tumor activity and a manageable safety profile. And it continues to be a valid first-line option in non-clear cell renal cell cancer. And we have had 2 real-world practice evidences comparing 2 different set of populations. What we understand is the standard options we can offer to elderly patients as well. Probably especially we can probably modify the TKA dose, probably give it at a slightly lower dose, probably to make it more tolerable for them. We don't have to devise a new regimen. Again, elderly population is a very heterogeneous population. Some are fit elderly, some are unfit elderly. It has to be tailored on a case-to-case basis. And with that, thank you.